Welcome everyone, and thank you for joining us today for the Immunizing Immunocompromised Adults webinar. The webinar is being offered by Immunize Canada with support from Merck, and for today's webinar we are joined by Dr. Susan Bowles, who will be moderating the event, and our speaker, Dr. Dipali Kumar. Welcome Dr. Bowles and Dr. Kumar.
Kumar is an Associate Professor of Medicine at the University of Toronto in the Division of Infectious Diseases, and she is a staff physician at the University Health Network. Her clinical and research interests focus on infections in transplant and immunocompromised patients, with specific interest in host immunity to vaccines and viral infections. Dr. Kumar has authored over 100 manuscripts, editorials, and book chapters, and is currently on the board of directors of the American Society of Transplantation. She's the editor-in-chief of the AST Handbook of Transplant Infections and associate editor of the third Transplant Infectious Disease Guidelines published in the American Journal of Transplant. So I would like to welcome Dr. Kumar, and I will hand over the presentation to her. So welcome, Dr. Kumar.
Thank you so much, Susan, and thanks to all of you who have taken time out from your day to attend. So for the next 40 minutes or so, we'll be discussing immunizing immunocompromised adults. These are my disclosures. The objectives for today will then be first to review the definition of immunocompromised in the context of vaccination, to review the suggested vaccinations for these immunocompromised populations, and also to be aware of updates, especially to live vaccine recommendations in the immunocompromised population. So let's start with a basic classification of vaccines. For the purposes of vaccinating immunocompromised persons, I'd like to divide up vaccines into live attenuated and inactivated, and those are listed on this slide. And I've highlighted for you the vaccines that are especially important for adults. So for example, in the live attenuated section, a shingles vaccine or herpes zoster vaccine is one of the recommended vaccines. In the inactivated vaccines column, you'll see that HPV, influenza, pneumococcal, and hepatitis B vaccines are especially some of the vaccines recommended for adults. Now, the Canadian Immunization Guide has a nice summary of the vaccines that are suggested for immune-competent adults. And these, you can see, consist of tetanus or Tdap every 10 years, pneumococcal vaccine, shingles vaccine for those over 60 and a consideration for those over 50 years as well, and annual influenza vaccine. And this chart assumes that you've been immunized with HPV as children, as is the case for many school programs in Canada. So I think before we get to immunocompromised persons, it's important to understand what makes up the immune system. So the immune system then consists of two components. One is innate immunity and the other is adaptive immunity. And very briefly, I'll tell you that innate immunity consists of elements that we are essentially born with. So these are toll-like receptors, natural killer cells, and complement. And these receptors and cells help us to recognize pathogens. They're our first line of recognition for pathogens. The other part of the immune system is adaptive immunity. And this is the type of immunity that's created by our past experience with pathogens or vaccines. And adaptive immunity can be further subdivided into humoral, this is our antibodies, and cellular immunity. These are our T cells, whether they're CD4 or CD8 T cells. Adaptive immunity is important because it is needed to fight off a virus when we are re-exposed to an infection, whether that's a natural infection or even a live vaccine, live virus vaccine. Cellular immunity is especially important for viruses such as varicella zoster virus and other types of herpes viruses. So then what is immune compromise? So I like to think of immune compromise in two ways. One is primary or congenital, and this is there are several different types of these. Over 80 or 90 different types of congenital immunodeficiencies exist. Then there are the acquired immune deficiencies, and this is what we see in adults, primarily what we see in adults. So these include HIV, inflammatory bowel disease, or inflammatory rheumatologic diseases, and in these cases we use biologic therapies that are immunosuppressive. There are also patients who fall into the category of malignancy and chemotherapy, whether that's hematologic malignancy or solid tumor malignancy. There are also transplants that occur. These could be organ transplants or hematopoietic stem cell transplants, which used to be called bone marrow transplants. And various people are on corticosteroids for all sorts of indications. So all these lead to a certain degree of immune compromise. And what I'll be discussing today are primarily the acquired immune compromising conditions, and those are highlighted for you. So immunodeficiency is a spectrum. I mentioned to you some of the immunocompromising conditions, but there are things we don't always think of that can also lead to immunodeficiency. So this includes malnutrition. The aging process itself leads to immunosenescence or a lower immune response. Several chronic diseases impact our immune responses. These include diabetes, kidney disease, especially dialysis, liver disease, chronic heart and lung disease as well. So in these cases, the persons with these conditions are at risk of infection. Vaccines are less immunogenic, but in these cases, vaccine safety, especially with live vaccines, is usually not an issue. So that's why I've separated these out from the earlier conditions. Now, why are vaccines especially important for the immune-compromised? Well, there are many reasons. One of the reasons is that there is a higher burden of vaccine-preventable diseases in the immune-compromised. Now, there's a lot of literature on this, so I've just summarized it into a couple of sentences. So, for example, pneumococcal disease is 25 to 30 times more common in transplant populations. In immunocompromised persons in general, we see a greater risk of shingles. The illness is more severe for vaccine-preventable diseases. So, for example, for influenza, rates of hospitalization are much higher. So up to 70% of transplant patients who develop influenza might be hospitalized. There's an increased risk of HPV-related cancers. And if you contract shingles, there is a greater risk of disseminated shingles. Some deaths have occurred due to vaccine-preventable diseases. There's also a higher viral or bacterial burden. So immunocompromised persons have the potential for spreading whatever they've caught to others. There's also prolonged shedding. So again, there's this continued potential for spreading diseases to others. This also leads to hospital infection control issues. And finally, really we have no proven treatments for some vaccine-preventable diseases like measles, mumps, or rubella. There are no antivirals that are known to work against these. So vaccination then becomes our first line of defense. So some of the general principles to remember are that the immune-suppressed are at increased risk of vaccine-preventable disease, but vaccines are not as immunogenic in these populations. So the timing of immunizations is really the key. So I would say try to immunize if you can prior to starting immunosuppression. So that's not always possible. So the other best time is at the point where immunosuppression will be the lowest. And I'll talk about these as we talk about the specific conditions. So for example, try to immunize before starting high-dose steroids, or in an HIV-positive person when the CD4 count is more than 200, etc. So we'll discuss these as we go along. So let me talk about some specific immunocompromising conditions now. So HIV patients. HIV we know is a T-cell disorder, and when CD4 T cell counts fall below 200, these patients become significantly immunocompromised. Or if they have a high HIV viral load, this can lead to significant immune compromise. The recommended vaccines for this population for adults are HPV, if not received in childhood, influenza, pneumococcal, and of course the Tdap booster. And these are recommended as early in the disease process as possible. Now, I always get the question about the live vaccines. So live vaccines in general could be given if the CD4 T cell count is more than 200, but there is limited literature on safety if the CD4 cell count is below 200. So definitely above 200, but below 200, we're not sure because of the limited literature. So in HIV persons, we have to consider some important vaccine-preventable diseases. And one of these vaccine-preventable diseases that I want to discuss in a little bit of detail is invasive pneumococcal disease. Now, I've given you a table here that goes through the incidence of invasive pneumococcal disease in various different types of immunocompromising conditions. In the general population, so the immune competent or general population, the incidence of IPD, or invasive pneumococcal disease, is 5 to 15 per 100,000 person years. If you look at the HIV population, this rises significantly. It's anywhere from 200 to 400, depending on the study you read. So several-fold higher. Again, in other populations like organ transplant or stem cell transplant, the risk is 25 to 30 times higher. We have two types of pneumococcal vaccines, the polysaccharide vaccine and the conjugated vaccine. The polysaccharide vaccine, as you know, has been available for many years. It covers 23 types of pneumococcus, which cause 90% of the disease. It creates a T-cell independent response, which allows for a short-lived antibody response with no memory creation. And I'll talk about this in the next slide. There are really no efficacy trials with this vaccine, but this is the only vaccine we've had for many, many years for adults. Now, the conjugated vaccine, or PCV13, has been available since the 2000s. Now it covers 13 most common serotypes. It's a T-cell dependent vaccine, which means that unlike the polysaccharide vaccine, you create high avidity antibodies, so these are well-functioning antibodies, as well as memory B cells. And we know that there is an efficacy trial, the CAPITA trial, that actually showed that the vaccine reduces invasive pneumococcal disease. Now, here's the detail that I talked to you about T-cell independent versus dependent response. And it's good to have at least a simple picture of what this means. So the T-cell independent response is what we get with the polysaccharide vaccine. And in this case, what happens is that we get the polysaccharide, which binds to the B cell receptor. This leads to cross-linking of the B cell receptor and eventually leads to an activated B cell. It actually requires no T cell help to do this. If we have a conjugated vaccine, so this is a protein conjugated vaccine, in this case, the protein or peptide antigen binds to the B cell receptor. It is internalized and then presented on the MHC2, or the major histocompatibility complex 2, which then interacts with the T cell receptor, and the T cell becomes activated. Once the T cell becomes activated, cytokines are produced, which then further activate B cells as well as create memory B cells. And these B cells produce a large number of cytokines, or a large number of antibodies, and as well produce a pool of long-lived memory B cells. So it's a little bit complicated, but I think it's good to understand that the conjugated pneumococcal vaccine works through T cells, whereas the polysaccharide vaccine is a simple B cell response. So what are the vaccine recommendations, the pneumococcal vaccine recommendations in Canada for immunocompromised adults? So you'll encounter two situations. There will be persons with no prior pneumococcal vaccine. For those persons, they require 1 dose of Prevnar 13, followed by 1 dose of Pneumovax, or the polysaccharide vaccine, with an interval of 8 weeks, and this is a minimum interval. Then 5 years later, they should receive a booster dose of the Pneumovax. Now, the other situation you'll encounter are persons who've had prior pneumococcal vaccine, and this will be essentially the Pneumovax that we've had for many years. In this case, you wait for a minimum of 1 year and can administer Prevnar 13, 1 dose. And after administering the Prevnar 13, they are eligible for another dose of Pneumovax. But there are some time criteria for the second dose of Pneumovax. One is that there needs to be an 8-week minimum between the Prevnar and the Pneumovax, and there needs to be 5 years from the prior pneumococcal vaccine. So both criteria should be fulfilled. And this is a little bit confusing, so I'm happy to answer questions about this afterwards. So that was HIV positive persons, where I had an opportunity to tell you about the pneumococcal vaccine. Now, what about persons with solid tumors? This is really a heterogeneous population. We have patients who are in remission. Some patients in remission will be awaiting a stem cell transplant. Some patients will be getting chemotherapy, so they may have active tumor. Maybe they present to you just prior to chemotherapy or post-chemotherapy, and other patients may have active tumor but are on no chemotherapy or possibly palliative chemotherapy. So what are the important routine vaccines for this population? So this is the population that is your breast cancers, lung cancers, colon cancers, etc. So these patients we want immunized with influenza vaccine, pneumococcal vaccine, so similar thing because they are immune compromised, the conjugate and polysaccharide vaccines both. They should, if they're within the right age group, have the HPV vaccine, hepatitis B, and then if not immune compromised, and I've put that in quotes, and over 50 years old, they are eligible for the shingles vaccine or the herpes zoster vaccine. So what does that mean when I say not immunocompromised in a solid tumor setting? Well, solid tumor patients may be immunocompromised if they've had chemotherapy in the past 3 months. So I would consider that group immunocompromised. Immunocompetent would mean those that have solid tumors that are in remission or that have limited disease, or they've received only limited radiotherapy. So they have very limited, let's say, prostate cancer for which they've received local radiotherapy. So those persons would still fall into the immunocompetent group. Now, as with everything in medicine, there are gray zones that would need expert opinion. These are patients who may have extensive active solid tumors, maybe metastatic disease, but no systemic therapy in the past 3 months. Maybe there are no plans for any chemotherapy in the future. So in this case, we would consider their life expectancy and discuss the risks and benefits of vaccination with the oncologist. So there are always these gray zones when we think of solid tumors. Now, interestingly, a small tidbit on the herpes zoster vaccine. There has been a study looking at herpes zoster vaccine in persons prior to chemotherapy. So this was a large cohort in California. This is the Kaiser Permanente cohort. Persons were aged greater than 60 years. They had either received or not received the herpes zoster vaccine at any time prior to chemotherapy. And you can see that those that did receive the herpes zoster vaccine had a lower incidence of shingles after chemotherapy. So none of these these patients were anticipating to get chemotherapy, but they had received the Zoster vaccine prior. So I think what this basically tells you is that it is important to encourage people to receive the vaccine, because if they are to develop immunocompromise later on, the vaccine may still be protective. So now let's move on from solid tumors to hematologic malignancies. This is another group of immunocompromised persons. So this consists of your AMLs, ALLs, CLLs, which are the chronic leukemias, myeloproliferative disorders, and multiple myeloma. So this is a very large group of patients. Now, when do we consider these patients immunocompromised? Well, if they have any kind of active disease. So if with any hematologic malignancy, people are immune compromised. They all have cellular immune defects, whether they're B cell defects or T cell defects. Certainly, if they're getting chemotherapy, they definitely are immunocompromised. Now, there are sometimes you get people who have active disease, but they're not treated. So, for example, people with low-grade CLL are not always treated right away. However, even low-grade CLL is an immunocompromising condition. Now, again, there are these gray zones. So, a person may have disease in remission after treatment. So in this case, I would consult with a hematologist to say, well, are these people still immunocompromised or not? So what are the routine vaccines for adults with these hematologic malignancies? Well, everyone should get the influenza vaccine, hepatitis B vaccine, as well as your conjugate followed by the polysaccharide vaccine. For any vaccine, however, I would delay vaccination for patients undergoing intense chemotherapy. So if they're undergoing an induction or consolidation therapy for leukemia, you could delay the vaccination. For anybody getting an agent called rituximab, which deletes all your B cells, you would defer vaccination for about 6 months. Now, influenza vaccine is a little bit special in that sense, in that if you deferred influenza vaccine for a long period of time, you may actually go the whole season without getting influenza vaccine. So in that case, you basically could give the influenza vaccine hoping for a partial response. And again, live viral vaccines, again, not while disease or chemotherapy is active, but wait at least until 3 months after the last chemotherapy and make sure the patient is in remission. So this is where contact with the hematologist, oncologist comes in. Now I'll move on to inflammatory diseases. Now the inflammatory diseases consist of inflammatory bowel disease, Crohn's or ulcerative colitis, rheumatologic conditions such as lupus and rheumatoid arthritis, as well as all the therapies that go along with these conditions. There are TNF-alpha inhibitors that are used for inflammatory diseases, such as etanercept, infliximab. There is also non-TNF immunosuppression. And let me just tell you a little bit about the agents that are used in inflammatory conditions. So I've divided these into 3 columns here. So there are TNF-alpha blockers, non-TNF immunosuppressives, and then others. So basically all of these are immunocompromising except for the others category, which don't have significant immunocompromise from a vaccine perspective. So if we look at the TNF-alpha blockers, these are your monoclonal antibodies. And this is a very short list, but there are several similar antibodies now on the market, and more of them are added all the time. So it is important to ask if somebody with inflammatory conditions is receiving any of these TNF-alpha blockers. So the Canadian Rheumatology Association does have some recommendations for vaccination in patients with the inflammatory conditions. And as you can see, what they recommend are influenza vaccines, pneumococcal vaccines, and hepatitis B vaccines. So the inactivated vaccine should be given to everyone, whether they're receiving any of the immune suppressive therapies such as methotrexate, leflunomide, sulfasalazine, or any biologic therapies. Herpes zoster vaccine can be given to persons on methotrexate, leflunomide, etc., but the CRA does recommend to avoid herpes zoster vaccine in those receiving biologics. And I'm going to talk a little bit more about this because we do now have some new data after these recommendations were published regarding herpes zoster vaccine and biologics. So, interestingly, as you would expect, the zoster risk in patients with inflammatory diseases who are getting these anti-TNF agents is elevated. So this was a study done in Germany. This was a large group of patients who were receiving anti-TNF agents such as etanercept, infliximab, or adalimumab. And the authors looked at the incidence of herpes zoster in patients that were receiving these anti-TNF agents, and you can see that the incidence rate is between 8.9 to 11.1 per 1,000 patient years. And if you compare that to control, and the controls were persons with autoimmune diseases that were not receiving anti-TNF agents, you can see that it's much higher. So the controls are 5.6 per 1,000 patient years, and the treated persons could go up to a shingles incidence rate of 11.1 per 1,000 patient years. And if persons were on prednisone along with their anti-TNF agents, this was associated with a much higher rate of zoster, almost twofold higher. So this was a study published in 2012. It was a large retrospective review of a Medicare cohort of patients who were more than 60 years old with autoimmune conditions. And you can see that in this cohort of more than 460,000 patients, they found that 4% received the herpes zoster vaccine. And what they first found was that in those that received the vaccine, there was certainly a lower incidence of shingles when these people were followed for up to 2 years. So it was 11.6 versus 7.8 per 1,000 person years in unvaccinated versus vaccinated. Now, interestingly, in these vaccinated individuals, there were 633 who were actually receiving anti-TNF biologics. And so, although the recommendation was not to vaccinate these persons were inadvertently vaccinated. And what the authors found was that in this group of 633 people, there were no cases of herpes zoster in the 6 weeks after vaccination, which essentially tells you that they did not actually have any adverse reactions to the vaccine. And in fact, when these patients were followed over time, it was noted that those that were vaccinated actually had a lower incidence of shingles overall. So not only was it safe to receive zoster vaccine if persons were on anti-TNF drugs, they also had a lower incidence of shingles. So the updated Canadian recommendations after reviewing these data were as follows. These were published in 2014, and they were that herpes zoster vaccine is still not indicated for persons with immune compromise, including high doses of steroids, chemotherapies, transplantation, or HIV. But it can be given to persons on low-dose methotrexate, azathioprine for inflammatory conditions, and that it can be now considered for persons on biologics, but on a case-by-case basis. So this would mean that you would have to, discuss this with your infectious disease specialist or your rheumatology specialist to see if herpes zoster vaccine would be indicated. Now, having said that, herpes zoster vaccine on the market is the live vaccine. However, we know that There is a subunit vaccine that has been evaluated in clinical trials. So this is an inactivated vaccine based on the GE glycoprotein of varicella zoster virus. In this study, there were greater than 16,000 patients, age greater than 50 years old. And the endpoint was confirmed herpes zoster, and the vaccine efficacy was 97%. So there was a very good vaccine efficacy for this inactivated vaccine. And there are several trials underway in special immunocompromised populations with this inactivated vaccine, and these include kidney transplant patients, leukemia, lymphoma patients, as well as solid tumor patients before chemo and on chemo. So we hope to have some more information about how this vaccine behaves in immune-compromised groups in the next 1 or 2 years. So now I'll move on to some transplant-related vaccine items. I'll first talk about solid organ transplantation. Solid organ transplant recipients include your kidney, liver, heart, lung transplant patients. And kidney is the most common type of transplant, so you may actually see these patients in your clinics for vaccination. So it's important to recognize the timeline of what solid organ transplant patients go through. So first, we have end-stage organ failure. There's a period of time on a waiting list before the surgery occurs, so they get their organ after waiting for a certain period of time. Following that, there is lifelong immunosuppression, and there may be episodes of rejection in between. So these patients are never really off immunosuppression once they have their transplant. So in fact, the best time to immunize is really before the transplant, when the patients develop end-stage organ failure and when they're on the waiting list. That's probably the best immunogenicity you're going to get with your vaccines. If they're not captured for vaccination before the transplant, then it's important to wait 3 to 6 months after transplant when they're on stable immunosuppression, and then they can receive your inactivated vaccines. But the response to vaccines after transplant will never be as good as it could have been if they were vaccinated before transplant. So we always say to try to get these patients vaccinated before the transplant happens. So this is just a summary of what I just mentioned. When possible, vaccinate before transplant. Live vaccines can be given before transplant, and if they are given, we generally wait 3 to 4 weeks to do the transplant because of the period of viremia that could happen with live vaccines. And then if they haven't been captured before a transplant, wait at least 3 to 6 months post-transplant once they're on stable immunosuppression. If they're having rejection therapy, then you don't want to be giving vaccines right in the middle of rejection therapy. They just won't work very well. So it's good to wait at least 1 month after rejection therapy, and generally no live vaccines after transplant. And this is a summary, and I've written the reference for you on this slide as well, of the guidelines for routine vaccination that are suggested by the American and Canadian Societies of Transplantation. And you can see that all the inactivated vaccines can be given before or after transplant, but the live vaccines can really only be given before transplant. This gives me an opportunity to talk a little bit about flu shots. You know that we have many different kinds of flu shots now on the market. We have your standard inactivated vaccine, which consists of 3 or 4 strains. The high-dose vaccine has also recently been licensed. There's an adjuvanted vaccine that's on the market as well, and there's also a live attenuated vaccine. Now, I've skipped over the intradermal vaccine because that's no longer being marketed. So for transplant recipients, there are studies with the adjuvanted vaccine and intradermal vaccines, but really none of the studies show that none of these special vaccines actually work any better than the standard vaccine. So still the standard vaccine is the one to use in in transplant recipients. And this is what we would be recommending unless there are further data to say otherwise. And I just want to show you that the effect of immunosuppression, the immunosuppression does impact vaccine response. So this is a very nice study that was published in 2013. And in this study, there were over 200 patients, and they were all receiving MMF, which is mycophenolate mofetil. It's one of the immunosuppressives used after transplantation. And you can see that patients who were getting high doses of MMF had a very poor response or poor seroconversion to influenza vaccine compared to those that were getting lower doses of MMF. Now, we can't really change the dose of MMF that we give to transplant patients because that's the dose that's preventing their organ from rejecting. But we can, however, have them, let them know that they may only have partial response with the influenza vaccine. So it's important for those around them to be immunized as well. Now, there is a Spanish study ongoing that's going to look at 2 doses of influenza vaccine in the same season for transplant patients. And right now it's finished accrual, I believe, and we're just waiting for the results of the study. So it will be interesting to know if 2 doses are better than 1. And now moving on to hematopoietic stem cell transplants, or the old bone marrow transplants. Again, it's important to understand the timeline of these transplants. So normally what happens is you'll have a patient with hematologic malignancy who will undergo chemotherapy. They'll achieve remission, and then there will be a very brief waiting time after which they will get their stem cell transplant. And they'll be in the hospital for about a month, and then they will have had their immunosuppression actually discontinued at 1 or 2 years if all goes well. So this is different from the solid organ transplant patient who stays on immunosuppression forever. In this situation, immunosuppression can be discontinued, and there is hope for normal immunity after about 2 years. So again, this is a immune reconstitution response in stem cell transplant patients. So what we get is that at 1 month, you have your neutrophils return. At 3 months, your CD4 T cells start to return. You also have functional asplenia ongoing, and you also have low antibodies in general. So across this time period, there is risk for infections, but vaccinations usually will not work very well. However, we do recommend to start vaccinations around the 3 to 6 month period to at least give some partial immunity. So the principles of vaccination in stem cell transplants: vaccination generally begins no sooner than 3 months. We usually don't give vaccination before transplant because, as you know, in stem cell transplantation, your immunity is wiped out completely. So any effect of prior vaccinations will be essentially nullified. Multiple doses are required in stem cell transplant because it's a naive immune system that needs to be built up. No live vaccines early post-transplant, but perhaps after 2 years, once the immune system has been reconstituted, you could give live vaccines. And some people have actually tried to give donors vaccine to try to see if there is any transfer of donor antibody into the recipient. And in fact, it has been shown that hepatitis B and conjugate pneumococcal vaccine antibodies are transferred from donor to recipient. But now that the majority of such transplants are using unrelated donors, it's actually logistically very difficult to find these donors and give them vaccines. So this is not a practice that really occurs. So what are the recommendations for stem cell transplant vaccination? I've just made a list here. Generally, everything starts around 6 months, except for pneumococcal vaccine, which starts at 3 months. And you can see that multiple doses are required. So for example, for pneumococcal vaccine, 3 doses of conjugate followed by 1 dose of polysaccharide vaccine is required. For your hepatitis B, again, it's the usual 3 doses, HPV, the 3 doses, etc. For live vaccines, they can generally be given at 2 years post-transplant. And it's important to get the hematologist involved if giving live vaccines to make sure that they believe the person is immunocompetent now. There's been no graft versus host disease. They're completely off their immunosuppression, and they've stopped getting IVIG, because some of these patients do get monthly IVIG for a long, long time, and this can actually affect response to live vaccines. Now, what I was just discussing with you was allogeneic transplantation. So this is where stem cells are obtained from donors that are unrelated or their siblings. There are guidelines also for autologous transplantation. So this is when patients store their own cells, which are then given back to them. Now, the difference in autologous versus allogeneic is that in autologous, immunity is retained better after transplant. There is no immunosuppression, there is no graft versus host disease, and vaccines can start earlier at 3 months post-transplant. And in fact, live vaccines could be given as early as 1 year post-transplant. Because remember, this is just the patient's own cells being given back to them. So really there is no immunosuppression with this. And finally, household contacts of immunocompromised patients can receive all age-appropriate vaccines. Live vaccines can also be given to household contacts, but of course not smallpox or oral polio. We don't really come across that very much in Canada anyways. Varicella transmission is rare and usually only when rash is present. And again, if it's an infant getting these vaccines or a small child, then a good hand washing after changing the infant diaper for the immunocompromised person, or if they can get somebody else to do this diaper changing, it's even better. Live vaccines. Live influenza vaccine can be administered to household contacts, and the only caveat there is unless the immunocompromised person requires care in a protective environment, and really that only occurs when the patient is getting an active stem cell transplant, and only for 1 month, so that situation doesn't arise very often. And so, in summary then, for any person with immune compromise, try to immunize prior to the onset of the immune compromised state if possible. Wait for 2 to 4 weeks before starting immunosuppression to give the vaccines a chance to work. That's again, if possible. The effectiveness of any inactivated vaccine will likely be less after the person has become immunocompromised. And the only exception there is hematopoietic stem cell transplantation, where it's a naive immune system, so all vaccines are given after transplant. And with regards to live vaccines, in ongoing immunosuppressed states, we really can't give live vaccines with some exception that I discussed, and this is the Zoster vaccine in inflammatory diseases. And again, almost all live vaccines can be given to close contacts. So with that, I will thank you for your attention, and I'm happy to take any questions.
Thank you, DePauli. We have one question, and that's slides. Someone's asking if we can have the PowerPoint sent to us. Now, the presentation has been recorded and will be on the immunize.ca website. I don't know if the slides will be made available. And that is the only question thus far. Are there any other questions? If there are, please type them into your question and answer section, and we can, Dr. Kumar can respond to them.
Right. Thanks, Susan. So this is a very heterogeneous group of patients, and there are many, many different immunocompromising conditions as I went through, and they all have slight variations in recommendation. And so, it is not an easy task.
Okay, we have another question. The question has to do with shingles vaccine. The question is, I heard the shingles vaccine is safer due to prior exposure in immunocompromised individuals. Is this similar? What about yellow fever vaccine, which would be novel to the patient, i.e. they wouldn't have, unlikely to have exposure to it? Is there any higher risk? Right.
So, so shingles, as you know, is a secondary vaccine. So, so the persons that are getting shingles should have generally had chickenpox before, and so they should be VZV IgG positive, technically. So yes, so it is felt that the shingles vaccine is probably it is on the safer side. However, we're kind of lacking studies, except for the studies that I showed you in inflammatory diseases. We're lacking these studies in other groups of immunocompromised persons, safety studies. So it is hard to make a general recommendation. Now, with regards to yellow fever vaccine, yes, so this is a primary vaccine. The person has clearly not seen yellow fever before. So for yellow fever is important in parts of Africa and parts of South America. So if an immunocompromised person wishes to travel to these areas, what they need is a waiver letter. So this is a waiver letter that says that they have a medical contraindication to receiving yellow fever vaccine. And with that, they can show at the border for travel. So it's certainly yellow fever vaccine, should not be given to immunocompromising persons.
Okay. Thank you. There's a third question. Do you use a protocol to ask, or are you aware of any protocol to ask about household contacts with immunosuppression as part of routine immunization?
So I'm not aware of a protocol. What I usually get are people themselves asking, is it okay for me to get the live vaccine because my family member has had a transplant or is immunocompromised in some way. So I'm personally not aware of a protocol that would say that, asking if the family members are immunocompromised. I mean, certainly we can ask if the person themselves, the patient who's coming for vaccination is compromised. But it's usually the patient themselves that's asking.
Okay. Another question around flu vaccine. Are you aware of any research being done around either high dose or adjuvanted flu vaccine, or even giving 2 doses of regular flu vaccine in a season to individuals who are on biologics?
So I'm not aware of there may be some ongoing trials, clearly, for adjuvanted or high-dose vaccines. Certainly, I'm aware in the transplantation arena, there are, as I mentioned, the 2-dose trials. There are also high-dose vaccine trials that are being planned. There has already been an adjuvanted trial that did not show any difference compared to the standard vaccine. In those on biologics, I'm personally not aware of whether these newer vaccines are specifically being tried, but it's a great area for research.
Okay. There's just a comment here from someone who I think is in public health that said in their health, in their department, they usually do ask if household contacts have an immunocompromised individual, if there's an immunocompromised individual in the household. So
yeah, that's great. Mm-hmm.
There's a question here about meningococcal disease in immunocompromised individuals. And I know you mentioned the meningococcal vaccine was noted in several of your slides. Now that we have the meningococcal B as well as the recommendations around the quadrivalent vaccine, do you have any quick tips around that in immunocompromised people?
Right. So I'll just say that it's different for different groups of immunocompromised people. So, as a general rule, the meningococcal vaccine is really for immunocompromised. It's only recommended for those with other risk factors. So those that are, let's say have on top of the immunocompromised, they also have complement deficiency, or they're traveling to a endemic area, or they have splenic dysfunction, etc. So in adults, we're not using the meningococcal vaccine as routine unless they have other risk factors. The exception to that, of course, there's always exceptions. The exception to that is in stem cell transplant, we're giving them 2 doses of the quadrivalent conjugated vaccine, because they all essentially have some degree of splenic dysfunction owing to the radiation that and the chemotherapy that they've gotten. So aside from that, just thinking about the groups of patients that I've mentioned, inflammatory diseases, malignancy and chemotherapy, persons on steroids, etc., only if they have other risk factors that put them at risk for meningococcal disease.
Okay, thank you. There's another question here about the shingles vaccines or other live vaccines on people who are on biologicals. Is there a difference between biologicals? So certainly we know that NACI has made recommendations about the doses of methotrexate and some of the non-biological disease-modifying agents. Are you aware of any research that shows that perhaps some biologicals are less problematic than others? Is there anything, are you aware of any information there?
Right, so that's a very good question. So to tease out the differences between biologicals is very difficult. What would be really good is if we could somehow measure how a biological is affecting a patient, how immunosuppressed a person is. But the problem is that any biological will affect an individual person differently. So it's really hard to say, even between biologicals, if one is more immunosuppressive than another, or if one has a greater dose effect than others. It really depends on the individual patient. So I think this is where, liaising with your rheumatologist would come in handy. So I'm not aware of any data that says one biological is really, different than another.
Okay, and there's just one last comment. I don't see any more questions. One last comment from someone from Ontario who indicates that the MEN quad is funded, 2 doses of MEN quad is funded for HIV positive patients. So just wanted to point that out. And are there any other questions before we close? Just give people a some time to type in case there are. Okay, if not, I want to thank Dr. Kumar for taking the time out of her day to present to us. This is very useful information. I know I'm going to take a lot of this back to my own practice, and since I'm teaching the immunology or immunization section, I think I'm going to use some of that information in my immunization unit. Thank you everyone for attending. So with that, I'd like to close the webinar, and thank you once again, Dr. Kumar, for an excellent presentation. And I see several comments popping up that say exactly that.
Thanks, everyone.